Hello, my name is Jessica Prete, and this video is an overview of my risk assessment project. This is the table of contents that states what each slide will be displaying. The client is a 44-year-old Indigenous Hispanic Latina female who is a full-time dental hygiene student. The client has a medical history of multiple psychiatric conditions, hypercholesterolemia, perennial allergies, and chronic pain, and the client takes medications as needed for each condition. The client has a family medical history of deaths by various types of cancer, and the client's sister also has psychiatric conditions. The client's other sister passed away from liver cirrhosis and also had severe asthma, anemia, and allergies. Although the client has a BMI of 26.1, which places them in the overweight category, the client is an athlete, and their lean muscle mass is what contributes to this measurement. Based on these managed systemic conditions that cause no substantial functional limitations and the client's vital signs that are within treatable limits, the client has been classified as ASA2. When completing the initial EO-IO exam, the client presented with bilateral TMD due to them reporting pain as well as distinct popping crepitus and a left deviation on opening. Their angle classification was Class 1 for both right and left canine relationships, and Class 1 tendency 2 for both left and right molar relationships. Their overjet was 3, their overbite was 6, open bite on 2, 15, and 6 through 11, and bilateral attrition on 30, 18, and 19. They had multiple areas of recession as well as abfraction on premolars. During the appointment, the client reported that they clench while running uphill, as well as they are an active long-distance runner, and this clenching is what the abfraction can be attributed to. The client also had Class 1 frications, bilateral Kray's lines, and a fractured lingual bar, which resulted from traumatic bike accidents. The lingual bar had been meant to maintain the client's straight teeth after having traditional braces. Here are pre-treatment intraoral photos of the client's oral cavity, and now I will discuss the client's gingival descriptions. The maxillary gingival descriptions depict generally healthy gingival tissues, apart from the localized dark pink gingival grooves on 2 through 5 palatal and 13 through 15 palatal. The mandibular gingival descriptions depict generally healthy gingival tissues, apart from the localized dark pink gingival groove on 22 to 27 lingual. As for the dental indices, the client presents with mild inflammation on gingival index, MBI of 0%, zero mobility, 0.9 BOP, or 0.9% BOP, and 14 for DMFT. The PCR was initially 28.8%, which places them in the fair oral hygiene status, and the periodontal probings were generalized 2 to 3, but one surface 30 mesiobuccal had a reading of 4 millimeters. The restorations and horizontal bone loss on these x-rays reflect the client's background on the native reservation with no access to running water and limited access to dental hygiene care. The closest clinic was a 6-hour drive away, and because of the lack of patient resources, the dentist primarily completed tooth extractions rather than preventive care. After the client was not living on the reservation, they had their caries restored, and they actively took steps to keep their oral cavity clean. There was no CAL value assessed, so the periodontal classification was done through radiographic bone loss, which was about 10%. The crown to root ratio was generalized 1 to 2 and localized 1 to 3 on 13 and 15 because of root resorption. Although these images depict active bone loss and fuzzy lamina dura in some areas, this does not line up with the clinical findings of the gingival descriptions and pocket depths. The client was classified as stage 1, grade A, because of the 10% radiographic bone loss, horizontal bone loss, no tooth loss due to periodontitis, and the maximum probing of 4 millimeters on 30 mesiobuccal, and the radiographic bone loss divided by their age came out to less than 0.25. They had no history of SRP, and they were used to having dental prophylaxis appointments every 6 months. Their scheduled treatment plan was to have one appointment for a full mouth dental prophylaxis with a recare schedule of every 4 months due to their diligence in home care, while still monitoring them. The anticipated treatment outcomes were to lower the PCR percentage by having less biofilm, maintain the current gingival health status as seen in the intraoral images, reduce caries risk, but the actual treatment outcomes were that the PCR decreased by 1% at one appointment and then significantly increased at the second reevaluation appointment. I interviewed the client about their current routine and found that it was extensive. The initial goal I gave the client was to use a sodium fluoride mouth rinse each morning as an extra protective factor regarding their moderate score on the Canberra assessment. At the reevaluation appointment, I found that the client was using the Natural Dentist Healthy Gums Anti-Gingivitis Anti-Plaque Rinse instead of the 0.05 sodium fluoride recommendation. I encouraged the client to maintain their current meticulous oral hygiene routine, and I recommended that the client get a prescription to Paradex, an antibacterial, to maintain clean furcation areas. Although both PCR scores from the reevaluation appointments were within the fair range, they significantly differed. As for nutrition, the client met protein and grain recommendations, but not fruit or vegetables or dairy. This was because of their hypercholesterolemia, where their doctor has told them to not have as much dairy, so they have vitamin D2 supplements to maintain that. The first goal I gave was to make a daily smoothie with fruits and vegetables. Their diet primarily consists of homemade whole foods, but the fermentable carbohydrates they consume is to help them with their sustaining their runs. They also do yoga and Pilates in addition to their cardio, and they drink more than enough water, including salt water to maintain their electrolytes. And although their acid was over 200 minutes daily, they report the fermentable carbohydrates they eat are necessary for their long runs. The client wanted to build muscle mass to gain 6 pounds, so I gave them the goal of adding wrist and ankle weights to strength train during current workouts while keeping up their hydration routine. The client did increase their fruits and vegetable consumptions through having whole apples and vegetables like carrots and cucumbers. The exercise greatly differed from the first diary because they didn't meet their exercise goal due to the long hours in clinic and their long lecture hours in class. They walked only instead of yoga, Pilates, and running, and they didn't add the ankle and wrist weights. However, the client did maintain their hydration goal, not with supplemental protein shake, but with their current hydration routine. I encourage the client to increase their vegetable snacks to 3 cups, such as 1 cup of carrots and 2 cups of cucumbers, as they were already eating these vegetables. The updated exercise goal was to do brief body weight exercises between cardio workouts, and the new hydration goal was to supplement the salt water that the client drinks for their current electrolytes to supplement it with flavorless protein powder to add protein with minimal effort. Here are 3 peer-reviewed journal articles that correlate to the client. The first interviewed Indigenous individuals with limited access to care and how it affects their oral health or lack thereof. This relates to the client because their early background of having little to no dental treatment and oral health education led to the decay of multiple teeth and eventual periodontitis. The second article discusses how bruxism and clenching affects athletes' oral health, and this pertains to the client's habit of clenching while running uphill, which led to the client's abfraction. The article also relates to the client TMD because the report from the study's participants say that the clenching during training can cause morpho-functional changes in the stomatognathic system regarding their muscle strain. This may have had similar effects on the client, and it's good that they're aware of their own habits and how it can affect them. The third article compares the anti-gingivitis efficacy of grapefruit seed extract herbal mouthwash with chlorhexidine mouthwash. The results of this article state that there is no significant difference between the gingival and plaque indices of participants who use the 2 different mouthwashes. This pertains to the OHI given to the client, because I had given the client instruction to use a chlorhexidine mouthwash, but they were already using an aloe vera mouthwash that had grapefruit seed extract in it. So the results of this article support that both mouthwashes are suitable options to maintain the client's oral health. One interesting experience I had with a client was observing their partial lingual bar, and I learned that their lingual bar had been meant to maintain the straightness of their teeth, and I found it interesting that the areas in which I found the widening of the PDL were on the teeth that had no lingual bar after the client had been in the bike accidents that fractured it. My overall considerations for this project are that I am grateful for the experience to see one client through the entire dental hygiene process of care. As for this case, I would change my recommendation to be sure that it's considerate for the client, such as not recommending a mouthwash with alcohol when the client does not drink alcohol. I would be more thorough in observing the client's OHI techniques rather than simply trusting that they are doing everything right if they tell me their current routine. I would ask more questions about their TMD and put more effort into researching it to see if there's anything I can do to enhance their comfort rather than worsen their TMD, and I would take more high-quality images of their restorations. For future cases, I need to improve overall in my critical thinking and application of current knowledge with client-specific needs. I would also take intraoral photos of specific localized inflammation or bleeding to show clients before and after once gingival tissue is healing to increase patient motivation and compliance. Here are my references. Thank you.